but let's make sure you have the right answers. So when you're studying this anatomy, you'll know what you're studying. And let's start with this arrow on the top left of the image up here. Who can tell me what this is pointing to?
Left collar.
Phrenic fissure. No.
Oh, it's a
Rib. It's going to be the left 12th rib, the last rib. So the left 12th rib. And I did tell you guys not to worry about counting ribs. If this is the only one, we'll make an exception because it's the last one you see. So if I asked you to label it on an image review exam, which I most likely will, I will say, please put a marker on the 12th rib, left or right. So the last rib you see, right there, you can't miss it. There's the left 12th rib. Okay, what did I tell you I call this?
lumbar spine.
Just the L spine. So as far as labeling the range, guys, even though I have an arrow just right here, it's going to cover this whole range right here because we're not numbering them yet. It's just simply mean the L spine. Although if you want to know, it's 1, 2, 3, 4, 5. But for now, we're just going to call that L spine. All right. How about right here? It's kind of just an empty space right here. But what's found right here? That's what we say. Don't be shy. Psoas muscles. Psoas muscles. So if I'm asking you to label psoas muscles on your image review exam, keep in mind you have this whole range here, you have this whole range here. All right. What is that? You all got it. X.
Left.
There you go. Left. Left iliac crest. You guys, be specific. We've got 2 of them. The left iliac crest. And 2 new ones here. But they're good to know. We didn't go over these on the PowerPoint. I would like you to go ahead and know what these are. This is obviously pointing to a portion of the pelvis, but what specific portion is that? Wide, flat, the ala. This is what's called the ala of the pelvis. This whole wide, flat portion. This would be the right ala right here. The right ala of the pelvis. And this one I actually forgot to let you guys know, but you know what bone that is? That's just the sacrum. Now there are a lot more parts to the sacrum, but once again we're going to keep it broad. For now we're just going to call this whole area, this heart-shaped bone, the sacrum. It's just going to be the sacrum. Any questions on that image? By the way, it's a badly centered KUB, if you want to know what image that is. Why is that badly centered? What did we talk about?
So for the pubic
You don't see
symphysis.
symphysis at all. At all. Anything else wrong with that image? It's pretty straight overall. There's no marker. Good eye. Anything else? Yeah, so we're steering a little bit too much to the left side over here. See how the crest is being cut off? Now sometimes they're going to be so wide that it's going to be cut off anyway, but look, we see the full crest over here. We're cutting it off over here. If I was to draw an imaginary line down the film, we'd see that we aren't centered the film correctly. We're centered too far to the left side. So we're centered too high and too left. That's what's wrong with that image. Anything else? Is the rest pretty good? How about this? Is this an artifact?
No. Well, it's indexed contraceptive. Is it a contraceptive?
So this would be an IUD device right here. That is an irremovable artifact. So we would document that there's an artifact there, but that's not an artifact that we can remove. But we want to make sure we document that on film. In case the radiologist has no idea what they're looking at. That does happen, unfortunately. Okay, good. Let's move to the right image, of which we have an upright abdomen. We have almost the entire abdomen on there. It's another badly centered film. But let's see what we can name. And we're going to start, once again, right here. Well, maybe. What is this? Right 12th rib. Right 12th rib. It's the last rib we see right there. That's calcifications coming off the other ribs there. Don't let that throw you off. Let's go to, what would this be? Talk about that whole area. Left psoas. This column would be the what? L spine. What's that?
is, or left as is?
Left as is, and be careful once again, guys. Remember, as is going to be this protrusion down here. Crest is up here. Crest as is. Crest as is. Do not mix these up because people always mix those two up. That's the left as is right there. And we can kind of see some air in it. We can see some fecal material. What part of what organ would this be pointing to? That's going to be the rectum. The rectum right there. Especially as a dead center. And be careful, especially if we're looking at air ones we can't see as well. If we're talking about sigmoid, sigmoid is always going to be sitting more to the left side. Rectum's in dead center. So rectum, sigmoid, these sending over here.
How do we know you're not pointing to the pelvic cavity?
Because we haven't got to pelvic cavity yet. Because that could be considered pelvic cavity as well, but we're not at that chapter yet, so it's just going to be rectum. That's what we've talked about so far. We have a marker, we have an upright marker as well. He's got a little bit too much of the body on there. Probably could sit a little bit higher. Any questions on that image? Anatomy not too difficult this chapter, right? It's a little bit less to remember. Well, let's look at it sideways then. We have a DQ, a left lateral decubitus. By the way, this tech marked this wrong. Does anybody know why? Should this be marked down here? Where are we supposed to mark on a DQ? At the top. We always mark the side up. So this tech, trash tech, I don't know who they are, but they didn't know what they were doing. But regardless, we can see some great anatomy on here. You might have to turn your head sideways a little bit. But let's start right here. What specific part are we pointing to right here? Be careful. What is that?
Is it the transverse?
Well, transverse is right here. Look, following the path, we're going up, and then we have what right here?
Hepatic flexure.
That's going to be the hepatic flexure, or the right colic flexure. This portion right here. It's the corner. It's all about the corner there. It's going to be the hepatic or the right colic flexure. Tongue tied there. What do we have over here then?
The splenic flexure.
So this would be our splenic or left colic flexure. So right colic, left colic, hepatic, splenic. By the way, on your DQs, they will always be oriented just like this. So learn this image. Reason being, if y'all remember, I said that we only ever do left lateral DQs. Does anybody remember the reason behind that? We discussed it. Now, why do we only do left lateral DQ abdomens? Because on the chest, we can do right or left.
So the
For abdomen, so if correct, so the air will rise properly and not be obstructed by the stomach. We want the stomach to be down. We want that right side up. Allow the air to rise up properly. Correct. Okay. What's this right here?
The ascending.
Ascending colon. Correct. So if this is the ascending colon, I'm just going to point to this right here. What is this? That's the cecum. This area would be what?
Transverse.
Transverse. This would be
Descending.
How about this right here?
Sigmoid.
And then finally what? The rectum. Good. But I could throw some random arrow in here. What does that point to? It's another piece of anatomy that I want you guys to be able to go ahead and label on the pelvis. It's a circle. I heard someone, I think Zimbu said, it's the obturator foramen. So those two holes on the pelvis on the bottom are called obturator foramina. Foramen singular, foramina plural. We have a left and a right. So I want you to make notes. We do want to go ahead and start labeling the obturator foramina. Something else we check when we're looking at landmarks aside from that pubic symphysis. Okay. Anything else? Well, what's all this? You see these little waves all over the image? This tech was very sloppy. You know what that is?
Oh, that's the sheet.
That was them trying to build the patient up with a sheet. It's also why you do not want to use sheets. See how ugly that is? A lot of times they'll use sheets like this, and it will actually be all the way up into the actual area of interest. So bad idea. We should use our positioning sponges if they're available, preferably. That's the superior way to position these DQs. All right, so over here we have a PA abdomen, and we'll talk about positioning, how we know that, aside from it being labeled, of course, but there's another way to tell, which we're going to talk about the positioning. But PA abdomen, we still label the same anatomy. The anatomy looks fairly the same, aside from the pelvis having a more sharper look to it. But what is this pointing at again? We've already labeled this. We're just looking at it in a different way. What is that?
The left colic flexure.
Once again, splenic. I heard someone say it's splenic or left colic flexure. This would be what?
Descending colon.
You are sleepy today.
Descending colon.
Descending colon. What was that part of the pelvis I told you on know?
Atlas.
That's the left ala. This column is called what again?
Lumbar spine.
The L spine. What portion of the colon is this?
Transverse.
How about this area here?
Ascending.
Wait, what?
Ascending.
I'm hearing descending and ascending. Which one is it? Ascending's on the right side. This corner would be hepatic slash
Right
right
colic
flexure.
flexure.
This color would be
Orange.
this word would be enrollment. Which I gotta get this done by Friday, or I'm gonna lose my benefits. Just a reminder. Okay. I think that's about everything on that one. Of course, we have those 12 ribs. A little hard to see on this one. There they are. Of course, the striations in this area would be psoas muscles. Is the anatomy making sense for this chapter overall, guys?
Yes.
Nothing too crazy? Or are we a little confused by it? Can't tell when you are on the quiet one. I don't know if that's because you're confident, you're sleepy, or what. No answer.
Feeling
Okay.
good.
Are we able to tell if that's a P or AP without the mark?
Yes, we can. We'll go over that when we talk about the positioning. Give you a preview. It's all by the shape of the pelvis. Look at. Well, let's move on. Man, we've got some better images here. These are beautiful. I love these. We use this in the PowerPoint, if I'm not mistaken. But great stuff we can label. Let's just go in order, because we can see the entirety of that large intestine. Let's start right here. What is this?
Cecum.
Cecum. This is what?
Ascending.
This corner is what?
Right colic flexure.
Going across, we have the
Transverse.
Back up to this corner, we have.
Splenic. Left flexure.
We go down.
Descending.
S curve.
Sigmoid.
And then down the
Rectum.
poop chute, right? But don't use the word poop chute. That was correct. Okay. How about this air-filled structure here? Stomach. Very good. This again is what?
12th rib.
Right, 12th rib. These striation areas, which you can't really see.
Alright, so
What about the top of the pelvis here? We're waking up now. Coffee's kicking. How about down here?
right S's.
Yes, right. As I think I heard as is on all that. This bone here would be what?
Sacrum.
Sacrum. What are we missing? So should this be repeated? Yes, it should. Good. Good. All right. Well, let's go in one over here. This is an example of a barium enema radiograph where we inject barium and air into the rectum to get a beautiful representation of the colon here. Now, you're going to know something very crazy about that image. Look how low the colon's dipping down. Remember we talked about that with body habitus? What body habitus do you think that is?
Asthenic.
That'd be an asthenic body habitus. See how low that goes? It's in the pelvis. It almost looks like it's falling out of the body, but totally normal. It does not affect their health. Kind of fascinating. With that being said, let's go backwards this time. Lots of great stuff to label. Let's start right here. What is this?
Rectum.
This is
Sigmoid.
here.
Descending.
This corner.
Splenic.
One way down here is
Transverse.
back up.
Hepatic.
This This is?
Ascending.
And how about here?
Second.
Does anybody remember what these little ridges in here are called? I didn't say the word on Monday. You don't have to know that yet, but I'm just curious if anyone remembers.
Hostras.
Hostra, very good. Hostra, excellent. Good. Now, I'm sure this is the one we're all looking forward to participating in clinic. Yes? That was my first day of work, like I was telling you. The patient exploded on me. Yes, everyone's favorite exam. Well, lucky for you, we don't do them as much anymore these days. They've kind of lessened in popularity overall, mainly because colonoscopies have become so much more affordable. These are done typically for polyp screening if you can't afford a colonoscopy. But they've become more affordable these days, and we don't think it's quite as much anymore. But they still do them. They still do them. Sorry to disappoint you. It's not as bad as it looks, I promise.
What position is the patient in right now?
They start supine.
Okay.
With the probe stuck up there, yes. Yes, it's uncomfortable.
What?
Huh?
Are they not in Sims?
What?
They're not in Sims position?
They start with the Sims if you roll them over.
Okay.
Sims position is used to do the insertion of the probe.
Okay.
So you're going to insert the enema probe into the patient's rectum, and you're going to inflate the little balloon, because our natural inclination is to push out when there's an insertion. So it's going to keep them from pushing the probe out. It's also going to keep that from being suctioned up as well. So that little balloon is going to keep it in place, which you can see it right here. There's the balloon.
Oh.
You can't really see it. There's the probe, there's the balloon right there.
So it anchors it right there.
Anchors it right there, exactly. Now for babies, we actually, just to give you an insight into pediatrics, we don't use balloons. Reason being, it can rupture the baby's colon. So what we actually have to do is hold it in place. So doing baby barium is not much fun. You have to, you get finger cramps. I always say you get finger cramps because to do a baby barium enema, you have to hold the probe and just squeeze the cheeks together and keep it in there. So as a tech, you're squeezing the baby's cheeks the whole time. And like your fingers start hurting. As long as it goes for a while, you're having to move them around while keeping the cheeks squeezed, and it's not the most comfortable exam to do. All right, last image right here. Beautiful small bowel follow through. And once again, these pieces of anatomy will be in the same general areas we talked about, but you'll see there's variances in the way they look and the shape, depending on body habitus. That applies to the small intestines as well. But I just got 4 arrows, all 4 we've talked about, starting all the way up here. What is this?
Stomach.
Obviously the stomach. This first portion here of the small intestine is called what?
Duodenum.
Duodenum, and that is unique in what way? Shortest and the
Widest.
widest, correct. Also, it's feathery in appearance. When you hear them say feathery, that's basically it looks feathery in appearance with the barium in there. It's all the little, what we call the villi, that start absorbing the nutrients of the food after it passes through the stomach. Also, can you see why it's called the C loop now? We're not talking about the C loop? There's your big capital C. So the doctor will say, I'm looking for the C loop, I'm looking for the C loop. When they say that, they're looking for this exact area right here. And it doesn't necessarily always show up when they're lying down. They may need to be on their side, they might need to be oblique, so they're gonna move them all over the place. And to give you some insight for these small bowels, I'll get to that in a second. I'm getting ahead of myself. What's this portion of the small intestine called here? Jejunum, and this would be,
Ileum.
and which of those 3 is the longest?
Ileum.
How does the contents dump from the ileum to the large intestine?
Ileocecal valve.
Ileocecal valve, correct. Very good, very good. Now, what's something about this image that you notice that you might be like, oh my God, anything speaking to you on that image?
What is those finger-like projection on top? What are those on the duodenum?
Here?
Yeah. What are these?
That's large intestine.
Oh.
That's ascending colon, that's the flexure there.
For the flexion.
But anything on that image speaking out to you in particular?
Wow. That's a floral.
This is a fluoro exam, 120 minutes. Wow. Now, does that mean they're under the fluoro for the whole 120 minutes? No. But one thing with small bowel follow-throughs, and I'm getting way ahead of myself, this is more a Rad Pro 4 topic, but just to quench your interest if you're interested, these exams can be as quick as 15 minutes. They can be as long as 48 hours.
Oh, wow. That's a little long.
Reason being, depending on the patient's condition, depending on their body habits, depending on just numerous factors, either food's gonna travel normally, very quickly, or very slowly. So in some cases, you'll be doing images up to 120 minutes, sorry, but not fluoro, just regular KUBs. What they'll do is they'll do the fluoro portion, and what they're looking for is for the barium to pass right here through the ileocecal valve and start filling up the colon. That means that the small bowel has finished, because they need to evaluate the ileocecal valve specifically with what they call a spot film. Until it's there though, they keep periodically taking images of the patient to check where the barium is. So like I said, that could be as quick as 15 minutes, 30 minutes, but sometimes it can go all the way to 120 minutes. So they're just chilling in the room with you for 2 hours. You're just chilling there on your phone, hanging out as well, waiting for that barium to pass. And there's a little trick they say, tell them to think about food, ask them what their favorite food is, ask them about some hamburgers, some steaks, whatever they like to eat. And that will naturally cause the digestion to speed up. Sometimes that still doesn't work. And sometimes, like I said, it's going so slow, and this happens a lot with babies. It goes so slow that you're doing images up to 48 hours later. And 48 hours later, it finally reaches that ileocecal valve. They gotta take the baby all the way back down from upstairs, bring them back to the department, and the doctor then does the fluoro spot film. So it can be very quick, it can be very, very long. So that's the nature of the small bowel follow through. Kinda cool, huh? All right.